Great.
Okay. Well, thank you. My name is Danelvis Paredes. I'm one of the 4-year neurology residents, and I'm going to be giving the Shortcase presentation today. I hope we will learn and review something from it. So this was a 30-year-old male. He has significant history of alcohol abuse, cocaine abuse, who presented with subacute lower and upper extremity weakness and paresthesias. He said that 2 months prior to presentation, he started to experience weakness on his legs and difficulty walking. And the way that he described it was that it started on his calf and eventually involved his thighs. This later involved the lower and the upper extremity with numbness and tingling and inability to hold his cigarettes. He also continued to have frequent falls. Now, 1 to 2 weeks prior to presentation, he also started to develop this feeling of food getting stuck into his esophagus, constipation with no bowel movement for about a week, and dark urine. Now, in terms of his physical exam, his cranial nerves and speech were intact. Motor-wise, he had a 4+5 throughout, very symmetric. Sensory-wise, he had a decreased vibratory sense up to knees on lower extremities and up to wrist on upper extremities. He also had decreased pinprick up to mid-forearm on bilateral uppers and mid-calf on lower extremities. He was areflexic. And skin-wise, he had a very interesting finding with erythematous rash on central chest and also erosive lesions involving hands and knees, but very minimal. So while the patient was at the ED, because there was this question of ascending symptoms, starting with his legs, then his arms, the emergency department decided to obtain a lumbar puncture to evaluate for immunocytologic dissociation. His LP was pretty bland, protein were normal, no nucleated cells. The patient also had an EMG nerve conduction study, which showed an evidence of sensory neuropathy, no motor involvement. So at this point, because of this constellation of symptoms, which included constipation, dark urine, paresthesias, the consult team very smartly saw hashtag Maria and Rhino, decided to obtain a very important test, which gave us the answer. And this was a spot urine test, which include aminolevulinic acid, ALA, and urine porphybilinogen, PBG, which were both high. There are still some tests pending to confirm what type of porphyria this is, which includes the fecal porphyrin profile, the deaminase activity, and the molecular genetic testing. So I want to use this time to talk about acute porphyria, particularly acute intermittent porphyria, which is what we think the patient had. And this is because as neurologists, this is always part of our differential, but we rarely actually get to see it. So for porphyria, as we learn in the medical school, this is caused by alterations in enzymes of the heme biosynthesis. Depending what enzyme is affected will be the type of porphyria that we are talking about. Now, in the case of acute intermittent porphyria, let's say like here at the right, just very briefly, we are in the liver, this is the mitochondria. On acute intermittent porphyria, what we have is this very important enzyme called porphybilinogen deaminase or PBG deaminase that is decreased or absent during acute attacks. So consequently, PBG is not converted into HNB. And you have these precursors running in the bloodstream, PBG, and also the precursor prior to that, which is called ALA or aminolevulinic acid. And it is consequently excreted in the urine, and that's how you can detect it. In terms of presentation, as I mentioned, attacks occurs over hours to days. It persists for days to weeks. For acute intermittent porphyria, the age range is 20 to 30s. And exacerbating factors. So for exacerbating factors, one important one is alcohol. And if you guys remember, this patient had history of alcohol abuse. And interestingly, in the last several weeks, he had increased his alcohol intake significantly from prior. Also, stress could be an exacerbating factor. For us as neurologists, it's very important to know that most antiepileptics are exacerbating factors, particularly phenobarbital. And also some antibiotics, particularly Bactrim, can be exacerbating factors as well. Now, why do we have this constellation of symptoms for these patients? And the reason is because these intermediates that are circulating in the bloodstream has neurotoxic effects. So what we have in terms of symptoms is neurovisceral, with significant pain and ileus. Then we can have peripheral neuropathies. They could be sensory and motor neuropathies. Interesting, if there's motor involvement, there tends to be proximal weakness first and then distal weakness. Then if there's CNS involvement, particularly hypothalamic involvement, you can develop SIADH with hyponatremia, seizures consequently, and PRES from the dysautonomia. Very rarely you actually get to see skin changes in acute intermittent porphyria unless there is renal failure. Now, in terms of treatment. So for treatment, we have a very important one, which is called Hymen. You give it over 3 to 4 days. And the mechanism of action of Hymen, what it does is that it reduces this very important molecule called aminolevulonic acid, and it does it by inhibiting ALA synthase. Now, this is a very costly medication, and a lot of the hospitals doesn't have it. So another alternative is using glucose. And the reasoning is because glucose inhibits ALA synthase as well. Also, this is very important if your patient is MPO because of an ileus, which was the case of our patient. You also have to consider give them glucose infusion. And of course, removing the exacerbating factor is important as well. Now, in the case of our patient, he received, of course, 3 days of Hymen treatment with the guidance of the hematology folks. His ileus and paresthesias actually improved. He was transferred to internal medicine for further management because at that point, we were just managing his ileus. Unfortunately, the patient left AMA while on internal medicine service. He presented 2 days later with altered mental status, hypotension, and elevated white counts. Sadly, this patient died from septic shock, and the thought was that this is secondary to aspiration from persistent vomiting in the setting of his ileus. So sadly, this ended up as a sad case, but the take-home message from this case is that if you have a clinical suspicion for porphyria, even if it's slightly, it's very easy to obtain a spot, PBG, and ALA, as well as porphyrin thesis. And then you can move towards doing the 24-hour test, as well as genetic testing. These patients could decompensate pretty rapidly, hence the importance of early detection. And the treatment for acute porphyrias, independently of what type there are, is Hymen and glucose. And that's my presentation. Thank you.
Thank you, Danelvis. That was perfect. So someone with ALA left AMA and really bad outcome, sorry, but a great presentation. Great presentation. All right, so today I'm not showing slides. I'm just going to do the intro. Today's speaker is Dr. Birgit Frauscher. Dr. Frauscher is a professor at the Montreal Neurologic Institute. She got her MD and PhD from Innsbruck Medical University in Austria, where she started her academic career till 2013, when she left Innsbruck to go to McGill, and then rose to her current rank of full professor. Her research involves a very interesting interaction of sleep, epilepsy, and brain physiology. She has more than 150 publications already at what is an accelerating pace in a career that promises great things into the future. She's the recipient of numerous international awards, including, as we discussed, the Ernst Niedermeyer Award from the Austrian Epilepsy Society. I knew Dr. Niedermeyer very, very well at Hopkins, and he was something of a hero of mine. She's the associate editor on the editorial board of 6 different journals. She is a valued international grand round speaker and we're very fortunate to have her here today. Dr. Frauscher's lecture is entitled, "Do We Still Need to Record Seizures? New Ways to Simplify and Improve the Pre-Surgical Workup of Epilepsy." So, Dr. Frauscher, I'll turn it over to you.
Thank you very much, Dr. Brian, for your kind introduction. So to be provocative, I could label the talk, "Do we still need to record seizures?" Or in other words, would be labeled "New Ways to Simplify and Improve the Pre-Surgical EEG Workup of Epilepsy." I have no disclosures related to this presentation. Now, I want to just take this one slide to present what my lab at McGill does. So basically, we have 3 research directions. And to do so, we employ quantifiable tools to understand neurophysiological and pathological processes. So the first research direction is towards the study of normal brain activity. And the main direction is on biomarkers of disease for both diagnosis and prognosis. And then I think that is something what people in Parkinson learned many years ago, but now we are here in epilepsy as well, that epilepsy is more than just seizures. And so the lab also studies the important interactions between sleep and epilepsy. And the ultimate aim is to improve quality of life in people with epilepsy. Now, outline of today's presentation is to provide a very brief introduction to epilepsy pre-surgical evaluation, show up issues with the current approach, then talk about ways to simplify and improve pre-surgical epilepsy workup, and provide an outlook on what I imagine could be pre-surgical epilepsy evaluation in 2030. So this is just a little reminder for the residents here. So how do we do epilepsy care now? So a patient has a seizure, and so then he might or might not have a diagnosis of epilepsy, and to do so, patients undergo standard EEG and structural MRI. And then, as we all know, they undergo anti-seizure medication trials. And then some of these patients, and actually it's a very significant proportion of 30 to 40% of patients, are drug resisting, meaning that they do not respond to at least 2 adequately chosen, adequately dosed anti-seizure medication. And this group of patients is very important, as they are responsible for 80% of the burden on our healthcare system. And so it's the same like in stroke, time is brain. And so we should very early on consider surgical workup and let our patient do surgical workup and then decide for surgery, because at the end of the day, surgery is the only option to cure epilepsy. So really, we shouldn't miss the time window to do so. Now, what are the various steps? Let me show phase 1 workup. So our patients undergo prolonged multi-day, low-density, usually 25-channel video EEG recording, structural 3 Tesla MRI, neuropsychological testing, and then additional imaging. And here at McGill, patients undergo FDG, PET, SPECT, fMRI, electrical and magnetic source imaging, as well as EEG, fMRI. But really, if we look at these exams, everything could be done in outpatient setting, except the prolonged multi-day low-density video EEG, which I really feel is the bottleneck in our workup. Now, a certain proportion of patients need to go one step further, which is the phase 2 workup with intracranial EEG, and it's approximately, in our case here, is 20% of surgical candidates, where we find discordant findings in phase 1 workup, or where there is a very close relationship to eloquent cortex. And basically, there are 2 techniques available. The one is stereoelectroencephalography. You can see here on the right an example of one of our more recent patients where we had such an implantation, or grid strips, and then some centers do a kind of a hybrid between both of them. Now, this is from a recent survey from the American SEG Consortium, published by Gavala et al. JCN 2020, where they could show that now also in the US and in North America in general, there is this increasing trend similar to what we do in Europe for many years, and also at the MNI since the 70s, to use SEG for phase 2 workup. And basically, according to this survey in this phase 4 centers, they found that SEG is favored in nearly all indications, except in case of epileptogenic cortex in close proximity to eloquent cortex. Now, I want to present you this study from Lara Yehi, because really this was a key study, because I think nobody in the surgical world ever doubted that SEG has less complications than grid strips. But there was always the discussion, is it the same effective, right? Because it's always a balance we have to keep. And so basically what she did here is she analyzed more than 1,400 patient cases from the study sites. And what she could show, and you find here the values, both unadjusted as well as with method for adjustment. It's called propensity matching, what she used here. And what she could show here is that patients who underwent grids had higher odds of subsequent resective surgery, but those undergoing SEG had higher odds of post-surgical seizure freedom. And not surprisingly, patients who underwent grid strips had higher odds of surgical complications. So what the authors concluded from that is that there is, at the end of the day, a comparative effectiveness of SEG at lower complication rates. So this is really also the final step, I think, what it needed to show that basically most cases can be done very well with SEG. And for example, centers I trained in Europe and also at the MNI, we basically never do grids or strips anymore. So now this is work one of my past postdocs did while being in the lab, that we asked ourselves the important question. We know that approximately 40% of patients who underwent this SEG procedure, and I'm saying, oh, there is not much risk. Well, the complication risk is 0.6%, but you know, admittedly, if it's your patient who has the complication and you can even die from it, then you know it's not fun to undergo this procedure if it's not really leading to a success. So the background, up to 40% of people do not undergo surgery subsequently to SEG. And that was what she wanted to see. If we look standard phase 1 workup, can we identify patients where we will not identify a focal seizure onset zone using this SEG? And so basically what she did is she developed a score and validated it in a total of more than 300 patients from 9 epilepsy centers. And at the end, we received something, the 5-cent score. I'm not talking a lot about the methods, but it was a complicated approach, mixing both historical classical statistical analysis with machine learning algorithms. But at the end of the day, she identified 5 factors which are important in that score. And that is focal MRI lesion, regional scalp ictal EEG onset, absence of bilateral independent spikes, strongly localizing semiology, and localizing neuropsychological deficit. And so this score, it's very simple. We have it available on our lab's GitHub page, and basically it takes less than a minute to enter the variables, and then you get an output. Evidently, it doesn't, and it's not meant to replace an epileptologist. I think nothing can ever replace an epileptologist, but it might help colleagues or centers who just start out with SEG, have less experience, to kind of get a feeling, will that SEG procedure be useful, or is it just going along with potential complications and a lot of effort and time for this patient? Now, in the next step, I want to talk about the zone concept. I think if we talk about epilepsy surgery, we cannot avoid to talk about the zone concept. And this was introduced by Rosenhoff and Lüders in Brain 2001. And so basically, we have all these different zones, as you can see, the seizure onset zone, the epileptogenic lesion, the symptomatogenic zone, the irritative zone, functional deficit zone. And what we do currently in our workup is we put a lot of emphasis on this seizure onset zone, and I'm really not sure that this is needed, and I will show you later why I think that this is wrong. And the reason we have all of these different zones is that at the end of the day, we want to identify the epileptogenic zone, which is defined as the minimal amount of cortex that is required to be removed to produce seizure freedom. And as this is a hypothetical construct, we require all of these zones to approximate the epileptogenic zone. And here we run already in our problems in pre-surgical evaluation. Now, what are issues as we do epilepsy pre-surgical evaluation now? So first of all, epilepsy surgery is still underutilized, and that is work from Nathalie Chetté, where she could show that it is used by less than 2% of amenable patients in North America. Another issue, I think, is that it is very time consuming, usually takes at least 1 week if we only need to do phase 1 workup, because we need to record seizures. And we know that seizures don't occur every minute, and especially in adults, it might not be even days. So it's really time consuming and requires hospitalization in specialized units called epilepsy monitoring units. Another thing which I always feel is paradox to explain to the patient is that evidently to get these seizures or to increase chances to capture seizures, we need to lower anti-seizure medication. And evidently, as a consequence, it can happen that patients have focal to bilateral tonic-clonic seizures with potential injuries or status epilepticus. And at the end of the day, 50% of well-selected candidates do not become seizure-free after surgery. And potential explanation might be that the SOZ is an insufficient proxy for the epileptogenic zone, or the epileptic network is larger than originally assumed. So that really means that we do well, but we still need to do better. Now, what could be potential conditions to achieve a more rapid workup? And what we need to do is we need to search for markers that are more frequent than seizures. Another thing I think we need to do is we need to combine multiple markers, as there is not a one-fits-all approach and we have different types of epilepsy. And at the end of the day, we also should translate markers from the invasive to the non-invasive EEG, because it would be great to spare these patients this additional invasive step. Now let's start with search for markers that are more frequent than seizures. So I will show potential markers available, such as interictal epileptiform discharges. High-frequency oscillation is a more modern one, but also on the market already 20 years or so. Background EEG, and then I will not touch that a lot, but connectivity markers more recently. Now, these spikes are the traditional seizure-independent marker of epilepsy, and I think nobody has an EEG rotation without having seen many of these spikes, and they basically define the irritative zone. And what we know already since the early times of Penfield and Jasper at the MNI is that they have a high sensitivity but a low specificity for the seizure onset zone. And this was nicely shown quantitatively here by the Marseille group by Fabrice Bartholomé, where he quantified the spike index as well as epileptogenicity by calculating a fast activity index, which he termed the epileptogenicity index. And he found that approximately half of patients had a good concordance between spike density and SOZ, and that was better in case of focal cortical dysplasia. And what you can see here is a mismatch in this patient here, where you see highest spike rates in the infrasylvian region and highest epileptogenicity rates in the suprasylvian region. Here we see a concordance in this patient here. But I think personally that these spikes are still a good marker, and I think it's really a matter how we look at these spikes. And there is evidence from the literature, it's not only what I think, but literature showed that shorter spike duration correlates with the seizure onset zone, spike origin correlates with the seizure onset zone, spikes with high frequency content correlate with the seizure onset zone, spikes with HFO identify the SOZ, and stable spike sources predict good surgical outcome. And that was one of the main themes of my current CIHR funding, where we wanted to prove that spikes are better than their reputation and that there should be a paradigm change. And basically that's work John Thomas did in the lab. It's currently work under revision. And so basically he investigated if certain spike types achieve a better performance than the current gold standard. And to do so, we applied a fully automatic spike detection that is incorporated in our lab's pipelines. And then basically that are the features that he extracted. It's a total of 135 features from the different vigilant states. For simplification, we separated between non-REM, REM wakefulness, and then these are features suggested to be potentially beneficial in the literature, but also from a signal analysis point of view, such as the trigger energy. That's basically what he then computed. And what he did is we had a total of 83 patients, of whom half had an angle 1A outcome. And I really think that is a very good outcome for this most difficult patient group. These are patients both from our center at MNI, but also from our collaborator, Philippe Cahan from Grenoble-Alpes University. And basically what John did, he let the detector run, he extracted the various spike features, and then classical machine learning approach with training set, test set, fourfold cross-validation to identify the best feature. I will not further talk on the methods, but on the main finding. And what he found is that the spike gamma index in wakefulness was the best marker. And he could show that this even performed better than the seizure onset zone for outcome predictions. And he showed that channels with have a spike gamma rate exceeding 1.9 per minute had an 80% probability of being in the epileptogenic zone. He then further tried various feature combinations, but that did not further improve the results. I was very excited when I saw that result, because what you can see here is it's really a marker that we can visually see when we look at our EEG, and that is just a standard filtered SEG signal between 0.3 and 250 Hertz. And you can nicely see here this spike. And what you can see before that spike, you can see here these gamma oscillations. So this is the filtered signal in the gamma band, 30 to 100 Hertz. And there's time frequency plot where you can see that isolated plot in the gamma range prior to the occurrence of the spike. And what was very interesting is also that we look, well, you know, is this a marker of a certain pathology which simply goes along with a good seizure outcome or not? And we could find there was discrimination in this box plots here for various pathologies such as hippocampal sclerosis, MRI negative patients, group of others, but it discriminated best for patients with focal cortical dysplasia, as you can see here. Now, what is interesting in these graphs here, so we have here seizure-free patients, non-seizure-free patients. We have here epileptogenic zone, which is approximated by the resection cavity, as these are the seizure ones here, the non-epileptogenic zone, and here presumed EZ, non-EZ, and then the various pathologies. And what you can see here in the color bar here is the wake spike gamma rate. And what you can see here is that a lot of red color here is in the resection cavity in the seizure-free patients, whereas this is not as expected the case in the non-seizure-free patients, which might be due to an incomplete resection. And what is also interesting, if we look at these patients here, where all is blue, meaning basically there is no wake spike gamma here. And that could indicate insufficient brain sampling. As everybody knows who does SEEG, it's a perfect method. We have only one problem, and that is insufficient brain sampling. So that's what he could show here. This is another very interesting, elegantly done piece of work from another student in the lab, Peter Klimisch at the time, where he could show, and that is something we know as clinicians since many years, but he could elegantly show it using signal analysis, that epilepsy surgery outcome depends on strong signal and stable sources. And then he calculated a measure which is called the spatial temporal spike dynamics. All the code is available on our GitHub page as an objective and easy to apply marker. And what he found, if he uses this marker of stability, he got best results if it's an 18-hour piece. So there is really benefit to have at least, you know, 1 day of recording. But that's just an example here where you could see here the strong source in this angle 1 patient, whereas this here is a poor outcome patient where we don't really see much of a source. We just saw these smaller peaks at various locations, and he did not do well. And what was interesting when he then did a simple logistic regression model, that he could correctly predict surgical outcome in individual patients with a model accuracy of 0.8%. And this was significantly better than when we looked at presence of a focal MRI lesion, which just performed at around chance level at 0.5. So we felt that this is a very interesting approach and easy to compute, and could further showcase how spikes might be useful. Now I will move on for the sake of time to high frequency oscillation. which are defined as at least for consecutive oscillation above 80 Hertz. And so we define various categories depending on frequency content between ripples, fast ripples, or very high frequency oscillations above 500 Hertz. And it's a promising new biomarker of the epileptogenic zone. Now, for those who haven't seen them, I just will show you how you can visualize them. So that's a 15-second page of one SEG electrode. Usually we have between 13 to 18 or even more such electrodes. But here you can see here in the left orbitofrontal region, the spikes here. What we need to do is we need to enlarge the time scale to 0.8 seconds per page. We then apply an 80 Hertz high pass filter. We enlarge the amplitude to 1 microvolt per millivolt. And then voila, you can see it here, these high frequency oscillations. So that's what we talk about in the next couple of slides. So what are issues of these HFO in clinical use? Well, we know very well that these HFOs are not only pathological, but also physiological, that really to make it ready for prime time in clinical routine, we need automatic detection, as it's very, very time consuming to screen the recordings. You can believe me, I did that in 2013, and then we stopped to do so in our lab. There are also limitations in HFO in determining the Z at the individual level. And then there is the ongoing question, what is the best time segment for HFO detection? Now, that is work from Julia Jacobs, a Swiss center work that she did at the time, where she could find that good outcome was correctly prognosticated in around 70% of patients. And higher rates of resected HFOs were associated with more favorable surgical outcome. And what we felt is one challenge, and which might explain that 30% are not correctly predicted, is that HFO rates vary according to various brain regions, and they can generate highly variable rates of physiological HFO. That is something which was early recognized but never addressed, because region-specific normative values of HFOs were lacking, and there was no atlas to differentiate between normal and abnormal brain activity. And that was basically something that we attempted in 2013, or started the project when I arrived in Montreal at the time, to create the MNI Multicenter IHE Atlas, the first release. We are currently working slowly on the second release, but at the end it was a 3-center endeavor at the time. Everything is available on our webpage, so you can either view the various regions and can get example on how activity looks during wakefulness, non-REM, REM sleep, or you can download all the data. It's all available, freely available MATLAB, and already first people published their own work using this atlas. So today I will just talk about the development of the normative HFO atlas. And so basically what we could find at the time is that HFO normative values are highest in eloquent cortical areas. And we really could have, if we look here, up to 30 per minute in normal cortical areas, which we termed the ripple-rich cortex. And you really can see that it varies a lot, whether you are in paracentral area or in the Heschel gyrus or in the mesiotemporal structures or in the occipital lobe. Whereas for fast ripples, these are the ones above 250 Hertz. We found that in healthy cortex, they're really very rare. And here the axis is very low, it's 1 per minute. Now, what we then concluded and what we hypothesized, and that's what Wilhelmik Zweipfennig, a student in the lab, did, is if we normalize HFO, can we increase the yield of ripples? And so basically what she could show in this work, which was just published in Epilepsy, is that HFO normalization increases localization, accuracy, and outcome prediction compared to standard HFO measures. And she found that this measure is particularly useful in case of ripple-rich brain areas. I will show you an example. And that, as expected, normalization of fast ripples did not further improve the performance. That's just an example of where she used standard values as here. And this is an angle 1A patient, meaning here is the resection that really here is the epileptogenic zone. And if she just used the standard values, then she had this false positives here outside the resection cavity. But when she applied this regional ripple threshold, then she could clearly identify the epileptogenic zone. In this patient, it improved localization accuracy. In this, all 3 methods worked, for example. Now, This is another nice work from Päivi Nivalainen, and I could collaborate with her when she was in Joel Gottman's lab. And basically what she could show is that fast ripples are better than their reputation, because we knew they are very specific, but sensitivity was lower. And so basically what she did is she used automatic whole night detection, and she was able to improve by doing so the accuracy from 72%, that was from visual classification of 5 minutes, to 86%. So longer might be better. Now, let's talk about the background. I think in SEG, it's very important to also carefully inspect the background and not only to focus on seizures or spikes. And abnormal slow wave activity, major alteration of background activity, or electrical silence, often a sign of lesion in area. FCD is a good example. And we have to keep in mind, and everybody doing SEG knows that background activity differs according to the brain region. That's just some example on how beta activity looks in the frontal lobe, how it looks very sustained around 25 Hertz, close to the motor cortex, as you can see here. And even in full wakefulness, as seen here in the hippocampus, we have this slow wave activity, as you can see here. But what we did in our Atlas project is we really calculated quantitative values to do so for the various sleep stages. And this is a lot of work I did together with our research associate, Nicolas van Ellenrieder. And so basically what you can see here, and I think it shows it nicely, that there is a certain signature in the brain of various distribution of frequency bands, where we have, independent of sleep stage or vigilance stage, more fast activity content here anterior of the brain and more slower frequency posterior of the brain. This was from an unsupervised clustering approach that he applied for the project, but I think it illustrates very nicely that we have this posterior to anterior gradient. Now, it's the group of Taylor et al. In Newcastle at the end of the day who applied it and looked, does it help us to predict our epileptogenic zone? And what he did do is he took the Penn normative cohort, and then he compared it to their own IEG from 62 patients. And when accounting for the normative variation regions, which were spared by surgery, were more abnormal than those resected only in patients with persistent postoperative seizures, which kind of points to the fact that it might be useful. This is just an example of an ILEA 1 or Engel 1A patient, where you can really see the abnormality is localized pretty much to the cavity. This is a poor outcome patient where this is not the case. It's more posterior to the cavity. Evidently now, if you know, we are very critical and we look under the area of the curve, then it would be perfect if these both distributions were completely separated. It is not, and the area of the curve is 0.75. It is okay. It's not stellar, but I think there is a lot of promise to continue to do these approaches and mix it. And by this, I just want to briefly talk about combining multiple markers, as there is not a one-fits-all approach. That's work from Petter while he was in the lab. And so basically, he could show that a multi-feature approach outperformed single features, and that non-REM sleep's the state of vigilance, which best identified the epileptogenic zone. And interestingly, adding information from 13.3 days to this 10-minute recordings did not further improve performance of the algorithm. That was very exciting, and that is what brought us finally our CIHR funding. Now, this is the various features that he looked at: oscillatory events, univariate spectral analysis, bivariate connectivity measures, and then interictal epileptic discharges. And I think the algorithm in the meantime was further improved by adding other features, but this is just the basic what we did at the time. And what he could show with this approach, that we had an area under the curve of 0.92, whereas if we looked, for example, at spikes alone, spikes, not specific spike features, but just spike as a group, it was 0.79, so clearly outperform. And here, that is nicely shown here. So we have the multi-feature in blue, and then multi-feature plus adding information on SOZ from 13 days was not better. This is nicely shown here. Again, I have to say it's only around 30 patients, right? So we need much more to make our point, but it's very promising information I want to skip this due to the sake of time. It was just a patient example. And in the following, I would like to talk a little bit on how we can translate markers from invasive to non-invasive EEG. And I will not talk about MEG today, but I want to talk about high-density EEG. And basically, high-density EEG is any EEG exceeding 64 electrodes. And there are solutions with up to 256 electrodes, such as from EGI, for example. And we get better source localization due to higher spatial resolution. Then evidently one has to say that, exceeding 100 channels, there is not much add-on, one has to say, but that's another topic. But what was shown is that this high-density EEG is not inferior to MEG. It might show some complementarity depending on the orientation of the dipole of the generator. And there are also potential advantages to MEG. So basically, we have unlimited possibility of recording. So at our center, basically, we do in every subject 48-hour recording on our monitoring unit. And then it's widely available. Everybody knows how to read EEG, right? So for MEG, it's a different story. And then it doesn't require a lot of resources. Such devices are pretty cheap and can easily be implemented in our doing. This is work from Broadbeck et al. From Geneva. And they did electrical source imaging in 152 patients with a sensitivity of 84 and specificity of 88%. And so these values were favorable compared to those of MRI, PET, and SPECT. And what they could show, not surprising for those doing source localization, but really we should take the patient's own head model and not just template. We all know that epilepsy often goes along with brain malformation, so that's not surprising that we should do that. And also that it's really much better that we use really this high density coverage and not just a low density EEG below 32 electrodes. And then what was also shown, it's work from Plummer et al. From Australia, that MEG is not more accurate than high density EEG. And that the best timing, there is still debate, but it seems the best timing might be usually the spike takeoff time and not the peak of the spike. Now, we wanted to push it a little bit further. And as I was very interested in high frequency oscillations at the time, I asked one of our PhD students, Tamir, at the time, that we try to localize this high frequency oscillations. And as you can imagine, it's not an easy task as the signal to noise ratio is really very, very low. And then again, all of these look different. So we need to do single event localization. So not an easy task, but at the end, what we did is a collaboration with a center in Niguarda, Milano, Lino Nobile. And so we got from him 10 recordings of patients who had an angle 1A outcome and 2-year follow-up. And so what he could show that even with this CAP solution, we were able to demonstrate presence of fast oscillations. And we found it in 6 of 10 patients, and this was more those with a surface closed generator. And we could show that fast oscillations localize to the epileptogenic zone and are complementary to spike sources. So here, it's just the unfiltered signal, the filtered signal, and time frequency plots. And you can see here some examples on how it looks. But here I want to focus on this patient. So basically, the epileptogenic zone is incorporated here in this cavity. And what you can see here, this is the fast oscillation localization, which is more posterior located here, whereas the spike is more anterior located. This is something that was shown by Tamilia et al. Also in the meantime, that there might be some complementary information to just doing spike source localization, or there is work from Bin He's group, also elegantly done in TLE patients. When you have more than one spike subtype, then maybe you should localize the spikes with associated HFOs as they are localizing better to the epileptogenic focus than those without. Now, to wrap up for the outlook, I really think that an outpatient pre-surgical evaluation without the need to record seizures could be feasible in 2030. And that could achieve a time-saving and complication-free outpatient epilepsy evaluation. it would allow to have resources enabling more patients to undergo pre-surgical evaluation. It could outperform current performance of surgical target identification, as we could see. And it could reduce also number of patients requiring invasive intracranial EEG. And ultimately, it would contribute to improve quality of life in people with epilepsy, but we are not there yet. There is still some work to do. And one of the questions is, within the ictal segment, is best to predict the epileptic sources. And that is something which is particularly relevant in case of interictal markers such as spikes compared to seizures. So that's recent work from one of our postdocs, Sana, which is in review, where she could show the channel overlap between wake and non-REM. And there was a very low overlap when we looked at spikes, which is easily explained because spike sources extend in the non-REM sleep. Whereas there was a pretty good overlap of nearly 80% if we look at seizures. So that really points to the fact, and we all know that if we do go for interictal localization, really the timing matters. What is the minimum segment length needed? So work pointing to is 18 hours, 20 hours around. And then ultimately will prospective large-scale trials confirm promising results from single center experience. This is always the next level, and that's one of the studies we currently undergo for HFO evaluation. And with that, I would like to thank people in the lab, all the funding sources, collaborators, and you for your attention. Thank you very much.
I said, thank you, Birgit. That was excellent. I didn't understand a word of it, but it's still excellent. It's so sophisticated. So anyone with a question, either raise your hand or put your name or question in the chat. We'll go to Prachi first, but I always have the right to ask the first question. So you've been staring at so many squiggles from people with drug-resistant epilepsy. Have you had any thoughts on why some epilepsies are drug-resistant and others aren't by looking at all these foci?
That's an excellent question. And there's for sure a lot more work to be done. Yeah, I think that could be a complete new research direction, moving me away from epilepsy surgery evaluation.
No, we don't want you to do that. We don't want you.
Well, you know, you always need something new, right? But there are some people start now using the HFOs, particularly, I think it's very promising in children, and there I'm jealous on colleagues in pediatrics because children are so much more active. And that's very beneficial if you look at markers such as HFOs, where, for example, it was nicely shown that if you look at this benign centrotemporal epilepsy of childhood or Rolandic epilepsy, what we learned when I trained 20 years ago, but what they did is they could see that those having these high frequency oscillations in the scalp, these are more than the ones who develop in a less benign version of this syndrome. Or for example, there are other studies which are very interesting that they looked in, it's UCL work, Bragin et al., where they looked at animal model of traumatic brain injury. And then they looked at those animals developing epilepsy versus those not developing. And they also found that presence of these ripples might give rise to epileptogenicity. At the end of the day, there is a lot one could look what makes it different. And these high frequency oscillations indeed in the scalp might be more useful for these indications than for the pre-surgical evaluation, because I have to tell you, it's really not easy to source localize them. And at least my students skipped then the topic after that and does now something else in the lab because it was so challenging. But yeah, there is a lot more to do. It's interesting. Thank you for the question.
Prachi, you have a question or comment?
I do. Thank you, Dr. Frauscher. So I had a couple of questions. The first question was, when you looked at the spike gamma index and you had that wonderful table that showed the different patients. I noted that a lot of them with the spike gamma index, the ones in red, were the ones with the FCD. Even the ones that were seizure-free were the ones that did not have a high spike gamma index. So do you think it's improper electrode placement, or is it something that you had touched on later on, that different areas of the brain and different neuronal properties generate different spike frequencies, or generate different frequencies, like in HFOs?
Yeah, that's a good question. I didn't ask my postdoc, and actually none of the reviewers asked that question, if it's certain anatomy. So I can easily ask him to look at this if the anatomy matters. I personally do not think so. But I really think there are different types, as we all know, of the FCD. There are the ones classical, which have a fantastic prognostication, and then there are the other ones who have not. That I personally also have the impression that very often people with STEPPDC5 mutations are not as benign focal cortical dysplasias type 2 as other types. So we had a couple of cases where I really thought we hit the ball and it will be a good outcome, and it ended catastrophic. Maybe we should write it up, this case series. What we suspected when we discussed the overall findings is really that we think it might be improper electrode placement. If we don't find, so basically it's a red flag. If you don't find the spike gamma, maybe you should question yourself, are we at the good spot? This is what we concluded from this, but we didn't do a sub-analysis to look at anatomy, but I can ask John to do that, and I send you the question. My guess would be it doesn't matter where it's localized.
Because even the study that was done by Patrick Chauvel, where they looked at the fingerprint analysis in seizures, the majority of their patients that had the perfect fingerprint pattern had focal cortical dysplasia, or they were mesotemporal epilepsy patients, but they're also the highest population that we have, that we see a lot of the times. And then one other question I had is, for HFO, for the high frequency oscillations, where you looked at them on the HD EEG, if you don't mind sharing, what filters do you use for looking at just the HFOs?
Pardon, what the filter settings, or
where you looked at the high frequency oscillation on the HD EEG, the raw EEG data looked quite different from the filtered data. It's like the 47th slide on your, yes, that one. So the unfiltered and the filtered, how did you get did you just remove the slow frequencies?
So yeah, it's true. He could have written this in the paper. He didn't. But it doesn't matter. So what he did, the unfiltered is basically the unfiltered signal. And in the filter, what he did for this work is he had filter settings of 40 to 500. 45. So basically the slow component is filtered away, and that's how then it looks. And then what he in addition did is he changed the amplification, okay, from the unfiltered to the filtered one, and you can nicely see here this blob in the time frequency domain, and you can see here at time 0 this was aligned to the peak of the spike. Because what we did here, because it was so challenging with these noisy signals, that we looked, and this is not fully automatic done. We now do it fully automatic in our next work, but this was done basically, it was me looking at all the spikes, and then we had the unfiltered, the filtered, and the time frequency plot presentation, and it was to say, yes, there is an oscillation or no, and then every single oscillation was localized using the wavelet extension of MEM, which is one of the distributed source models developed by one of my technical collaborators, Christoph Grover and Shomarkin.
Okay, we have two other questions, Dr. Subai and then Dr. Vestal.
So, Rich, I will ask for Dr. Subai. We're all in a room together. This is
okay.
Thanks very much, Birgit. That was fantastic. Two quick questions. One is infraflow activity. You didn't talk much about it. Does your lab look at that? Do you find value to that? And secondly, have you used many of the initial techniques that you described in, in terms of spike analysis and so on? In a practical sense, have you used that to limit the number of seizures you're currently recording in your patients, or is this not yet ready for prime time?
Mm-hmm. So the infraflow activity, I think it's something very interesting. We are planning to look at that and combine it together with HFO. It's something, just a recent paper in brain communications by the IKEDA group was publishing that there is also additive value to look at both at seizure onset. So the reason we didn't look at it was our amplifier, and only since 2017 we use the Nihon codon, and so we can have the time constant of 10 seconds. So we will look at that in the future. It's on our plan, and I really think it will be useful as well. The second question is our practical doing. So what we currently do, yes, we imply it in our reports, because basically the spike analysis and HFO analysis is fully automatically implemented. And basically the only thing you need to give our engineer is 10 minutes of recordings or whatever. You can even give the full night, it doesn't matter. And he lets the analysis run, and then you get these additional plots that we can implement in our reports. And I have to say it works very, very well. Evidently, it needs an epileptologist to supervise. Now, if we limit recording of seizure, well, so far we are still more at the proof of concept study. I mean, we had a couple of patients where we didn't record spontaneous seizure, where we could stimulate seizure, and then we told the patient, well, look, we can either now do nothing, implant another time, or we resect based on the stimulation result and interictal markers, but you need to know that this is not a standard of care. Some patients decided to do so, and they had good outcomes. I think we are ready for it, but I think the next step is really to have multi-center studies, prospective studies.
The next question is Dr. Vestal. Matthew, do you mind introducing yourself to the crowd and then ask the question?
Absolutely. Thanks so much, Dr. O'Brien and Dr. Frauscher, for your work. My name is Matty Vestal. I'm one of the pediatric neurosurgeons here at Duke. And Dr. Frauscher, I think from the neurosurgical perspective, I keyed to one of the original observations that you had, which is how difficult it is to get patients in either for phase 1, let alone for phase 2. And I was wondering, particularly from the pediatric perspective, since the other observation that you had made that I was particularly sensitive to is how different pediatric workups are from adult workups. And as you can imagine, it's even more difficult given the number of people, parents and children that you have to get in for phase 1 in kids, to get kids in as opposed to adults for that bottleneck that you described. And the question that fell out of those two observations for me was, in your work, have you stratified any of the sort of predictors of surgical success in terms of adult versus pediatric populations? And if you haven't, does it seem that any trends are falling out in terms of which one of these different markers might be more successful for kids?
That's an excellent question. I work at an epilepsy surgical center, and so our pediatric side is a couple of kilometers down the road. It takes 40 minutes to go there in rush hour, but we started now some collaboration. So for example, I helped them to build the high density EEG program there, and we do their analysis for the HFO analysis and EEG fMRI as well. I didn't specifically, at least in my work, differentiate. In my work, all patients are above age 15 because these are the ones that we host in our center. But the main difference, I think, and there I'm really jealous, is that the non-invasive HFO detection is so much better in children as opposed to adults. I think this is really, and it might be because they are more active. It might be because the very young have a less thick skull compared to adults. So I think there is a lot of potential. And it was, for example, nicely showed. I just cited a work last year from adults from Julia Jacobs' lab, where she could show that a child had a first seizure. And then they did this CALP EEG, 25-channel EEG, and those who had HFOs, that were those who developed further along the road epilepsy. So I think there is a lot of nice options for children, but I didn't specifically look, for example, you could do the same pipeline we did for the spike gamma index. We did it in adults. You could let it run in children. It wouldn't be much work because everything is ready to go. One just needs the data set selection.
Thanks so much.
All right, everyone. Birgit, thank you so much. That was absolutely amazing and packed so much substantive work into what is still a very young career. And, you know, we look forward to what you do in the future. And for everyone watching and engaging with the questions, thank you all so very much. And everyone have a safe day. Bye-bye.